Hello, I'm Dr. Kaylin Lane. I'm a psychiatrist currently practicing in rural South Georgia. I'm a native of Georgia and attended the University of Georgia in Athens and the Medical College of Georgia in Augusta. After graduating from medical school, I then went on to complete residency training programs at the University of Kentucky in Lexington. While at the University of Kentucky, I was trained in general psychiatry as well as child and adolescent psychiatry. After completing my residencies, I went on to complete a forensic psychiatry fellowship at Emory University in Atlanta. After completing all of my training, I moved to Alabama, where I worked in community mental health for approximately a year and a half. I then returned to Georgia and joined a private practice, where I worked for 5.5 years. About 6 years ago, I returned back to my hometown in Southwest Georgia. Since that time, I have been practicing almost exclusively remotely via telemedicine or telehealth. I'm currently the medical director of Unison Behavioral Health, a community service board based in Waycross, Georgia. Unison provides services to individuals with mental illness, substance use disorders, and intellectual and developmental disabilities. In addition to serving as medical director, I provide direct patient care to the clients we serve. Almost all of this is done exclusively via telemedicine or telehealth. The objectives of my talk today are to discuss autism spectrum disorder, specifically diagnosis, prevalence, etiology, assessment, and treatment. First, I think it's important to compare the DSM-IV definition of autism spectrum disorder to the current DSM-V definition. The DSM-IV defined pervasive developmental disorders, which were included in a chapter entitled Disorders Usually First Diagnosed in Infancy, Childhood, or Adolescence. These pervasive developmental disorders included autistic disorder, Rett's disorder, childhood disintegrative disorder, Asperger's disorder, and pervasive developmental disorder not otherwise specified, which included atypical autism. The current edition of the DSM-V, includes autism spectrum disorder under neurodevelopmental disorders. Other diagnoses, which are often comorbid with autism, included in this chapter are intellectual disabilities, which were formerly known as mental retardation, and can be specified as being mild, moderate, severe, or profound. Global developmental delay, as well as unspecified intellectual disability or intellectual developmental disorder. Also included here are communication disorders, language disorder, speech sound disorder, childhood onset fluency disorder or stuttering, social pragmatic communication disorder, and unspecified communication disorder. Autism spectrum disorder, of course, falls in this category, and there's more to come on that. Also, under neurodevelopmental disorders, there's attention deficit hyperactivity disorder, or ADHD, as well as other specified ADHD, unspecified ADHD, and specific learning disorders, which can be qualified as mild, moderate, or severe. Motor disorders, including developmental coordination disorder, stereotypical movement disorder, and tic disorders. And then other neurodevelopmental disorders, including other specified and unspecified neurodevelopmental disorders. So why do we call autism a spectrum? Because, as Dr. Stephen Shore said, if you've met one person with autism, you've met one person with autism. We can talk about being on opposite ends of the spectrum. So on one end of the spectrum, we might have individuals who are nonverbal, severely developmentally delayed, as well as intellectually disabled. On the other end of that spectrum, we could have individuals who have IQs in the superior range with no language or other developmental delays. So this slide illustrates these two ends of the spectrum. These are based loosely on two former patients. The first was Justin. He was nonverbal, not potty trained, was currently educated in a self-contained special ed classroom. He would grab anything of interest to him, the drink off my desk, the diaper off of a toddler in the waiting room. He watched videos on his iPod or YouTube. He was very hyperactive, impulsive, irritable, and sometimes aggressive. He was currently taking a stimulant, a beta blocker, an atypical antipsychotic, an SSRI, and receiving IEP services through his local school. On the other end of that spectrum was Sheldon. Sheldon had a superior IQ. He was being homeschooled due to being bullied at his previous public school. He frequently lectured about things that interested him. One day I got a lecture on metamorphosis during an appointment. He was in the process of writing a book. He suffered with depression, suicidal ideation, and irritability. He was prescribed an atypical antipsychotic, an SSRI, and individual therapy. So let's look at DSM-5 diagnostic criteria for autism. These include persistent deficits in social communication and social interaction across multiple contexts. These are manifested by the following: deficits in social emotional reciprocity. This could range from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interests, emotions, or affect. This might also include failure to initiate or respond to social interactions. Additionally, deficits in nonverbal communicative behaviors used for social interaction, ranging, for example, from poorly integrated verbal and nonverbal communications to abnormalities in eye contact and body language, or deficits in understanding and the use of gestures, to a total lack of facial expressions and nonverbal communication. Additional diagnostic criteria include deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, all the way to the absence of interest in peers. Restrictive and repetitive patterns of behavior, interests, or activities manifested by at least two of the following, currently or by history. Again, these are illustrative examples, not exhaustive. One would be stereotyped or repetitive motor movements, use of objects, or speech, including motor stereotypies, lining up of toys or flipping objects, echolalia, and idiosyncratic phrases. Insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. For example, extreme distress at the smallest change, difficulties with transitions, rigid thinking patterns, greeting rituals, the need to take the same route or eat the same food every day. Highly restrictive fixated interests that are abnormal in intensity or focus. For example, strong attachment to or preoccupation with unusual objects, excessively circumscribed or perseverative interests. Hyper or hypo-reactivity to sensory input or unusual interests in sensory aspects of the environment. For example, apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. Of course, the symptoms must be present in the early developmental period, but may not become fully manifest until social demands exceed limited capacities, or may be masked by learned strategies later in life. Symptoms can cause clinically significant impairment in social, occupational, or other important areas of functioning. These disturbances are not better explained by intellectual disabilities, including intellectual developmental disorder or global developmental delay. Intellectual disability and autism spectrum disorder frequently co-occur. To make a combined diagnosis of autism spectrum disorder and intellectual disability, social communication should be below that expected for general developmental level. ASD Specifiers. With or without accompanying intellectual impairment, with or without accompanying language impairment, associated with a known medical or genetic condition or environmental factor, associated with another neurodevelopmental, mental, or behavioral disorder, and then ASD with catatonia. There are various severity levels of autism, and these are based on the current severity of criterion A, social communication, and criterion B, restrictive repetitive behaviors. Level 1 are individuals requiring support. Level 2, those requiring substantial support, and level 3, those requiring very substantial support. Now that I've been through the DSM criteria, I like to go through the criteria again in what I call the Cliff Notes version. This is much less cumbersome and I think much more user-friendly. So, Autism includes deficits in social communication and social interaction. Number 1, deficits in social emotional reciprocity. These are individuals who talk to you or talk at you, but not with you. Deficits in nonverbal communicative behavior, including eye contact, facial expressions. Deficits in relationships, basically peer problems. Restrictive, repetitive patterns of behavior, interest, or activities. Movement, use of objects or speech, for example, hand flapping, lining up toys, echolalia, or scripting, which is repeating phrases or even entire conversations from TV shows or movies. Insistence on sameness, almost OCD-like behaviors, rituals, and routines. Obsessions. These are excessive interest or fixations. And number 4, sensory issues. So let's talk about how autism presents in the real world, or at least in my world as a child and adolescent psychiatrist. I often hear from parents that they knew something was wrong with their child within the first year. As babies and toddlers, individuals with autism are often fussy. They may cry all the time, not want to be held or comforted or cuddled. Many also display sensory intolerances. Particularly different types of clothing can be very bothersome. They may not like seams in their socks, or they may have a great deal of difficulty tolerating anything that is form-fitting, such as underwear. They frequently are very sensitive to textures of food, which can make feeding quite challenging. And they're also sensitive to noises, sometimes even everyday noises such as laughter or chewing. Many of these individuals early in life display some traits that we might think of as consistent with OCD or obsessive compulsive disorder. These might include lining up their toys and being intolerant of even small changes in their environments. They're often overly interested in things, not just normal toddler interests in Mickey Mouse or certain toys, but for example, I had a patient who was 3-year-old. He was obsessed with lawnmowers, not just making lawnmower noises, but all the different brands of lawnmowers, and he could tell you all about the different brands of lawnmowers and the different manufacturers. I also treated a young lady who, when she was about 5 years old, became very interested in owning her own home, and she collected the free real estate magazines from anywhere they visited. Another thing that I've found to be common is that I feel as though girls often fly under the radar longer than boys. But often puberty can be a tipping point for girls with ASD. And this might lead to their presenting clinically with either depression or anxiety, and can eventually lead to an ASD diagnosis. So in order to identify what's atypical, we need to know what is typical. This is just a basic review of typical developmental milestones. Many of you are already quite familiar with these, but I've included them as a review, and in case there's anyone who is not trained in medicine that might be accessing this presentation. So at 3 to 4 months of age, we expect babies to watch faces with interest and follow moving objects. They'll recognize familiar objects and people and smile at the sound of your voice. They'll start to begin to develop a social smile and even turn their head towards the sound. By 7 months, we expect that most babies should be responding to other people's emotions, and they enjoy face-to-face play. They can find partially hidden objects, and they explore the world with their hands and their mouth. They'll struggle to reach an object if it's out of their reach. They'll respond to their own name and use their voice to express joy and displeasure, babbling chains of sounds. By 1 year, most children should enjoy imitating other people and even imitating sounds. They'll enjoy simple social games. They'll learn to explore objects and find hidden objects. They'll respond to no, use simple gestures such as pointing to get an object. They'll babble with changes in their tone. They may use single words, including dada or mama or uh-oh. They'll turn to the person who's speaking when his or her name is called. By 2 years, children frequently imitate the behavior of others, and they're often excited about the company of other children. They should understand several words. They can find hidden objects, even those that are deeply hidden. They can point to named pictures and objects, begin to sort things by shape and color, and begin simple make-believe play. They recognize names of familiar people and objects and follow simple instructions. They should also combine 2 words to communicate with others, such as more cookie? By 3, children should express affection openly and have a wide range of emotions. They should be able to make mechanical toys work and play make-believe. They can sort objects by shape and color and matching objects to pictures. They should be able to follow a 2 or 3-part command, use simple phrases to communicate with others, such as go outside, swing. They should use pronouns, I, you, me, and some plurals, such as cars and dogs, although they may not always do this correctly. By 4, a child should be able to cooperate with other children and be increasingly inventive in their fantasy play. They should be able to name some colors and understand concepts of counting and time, speak in sentences of 5 to 6 words, and be able to tell stories, speaking clearly enough for strangers to understand. They should be able to follow 3-part commands and understand the difference between same and different. By 5 years, most children will want to be like their friends. They like to sing, dance, and act. They should be able, in part, to distinguish fantasy from reality, what's real and what's pretend. They should show increased independence. They should be able to count 10 or more objects and correctly name at least 4 colors. They can speak in sentences of more than 5 words and tell longer stories, sometimes quite long. ASD prevalence. Currently, the prevalence of ASD is felt to be between 1.5% and 2.5%. You'll see that it's 3.54% of boys and 1.22% of girls. According to DSM-5, it's still unclear whether the higher rates reflect an expansion of the diagnostic criteria compared to DSM-4. DSM-5 now includes subthreshold cases. Possibly, this higher rate of prevalence is related to increased awareness, differences in study methodology, or possibly a true increase in the frequency of autism spectrum disorder. The CDC's Autism and Developmental Disabilities Monitoring Network monitors prevalence of autism. The prevalence estimates are based on data from 4 years prior. The 2020 report is based on 2016 data. This illustrates the rising prevalence of autism, and as you can see, based on the 2020 report, current prevalence is 1 child in 54. So now we're going to talk a bit about the etiology of autism. And I like this quote from Dr. Temple Grandin. What would happen if the autism gene was eliminated from the gene pool? You would have a bunch of people standing around in a cave chatting and socializing and not getting anything done. So the big question, what causes autism? And the answer is, of course, we don't entirely know. However, there are some things we do know. There are risk factors for autism. Environmental risk factors. These may include advanced parental age, low birth weight, including extreme prematurity, multiple pregnancies, fetal exposure to Depakote, pregnancies spaced less than 1 year apart, and likely many others. Of note, prenatal vitamins with folic acid taken prior to conception and throughout the pregnancy are thought to reduce the risk of autism. There are also genetic and physiologic risk factors. Heritability estimates are anywhere from 37 to over 90% based on twin concordance rates, and there are likely multiple different genes involved. Current research trends in autism are looking into immune dysregulation, inflammation, oxidative stress, mitochondrial dysfunction, and environmental toxicant exposure as possible causes of autism. Fragile X syndrome is an X-linked condition that can have a pre-mutation or a full mutation. Individuals with Fragile X syndrome frequently have narrow faces, large ears, very flexible fingers, and are noted to have large testicles. They frequently have mild to moderate intellectual disability and often have seizures. Roughly 1/3 of individuals with Fragile X syndrome have features of autism. And Fragile X syndrome is unfortunately very common. 1 in anywhere from 130 to 250 females are carriers, and 1 in approximately 250 to 800 males are carriers. So let's talk about what does not cause autism. Vaccines. And there's a link here to a website. And I think I want to take just a minute and say that again. What does not cause autism? Vaccines. Commonly comorbid mental health conditions. So, along with autism, many individuals also have other mental health conditions. So all of the other neurodevelopmental disorders, which we discussed earlier in the presentation, are often seen comorbidly with autism. Anxiety disorder, depression, mood disorders, and disruptive behavior disorders. There are also medical conditions commonly associated with autism. These include epilepsy, sleep problems, and constipation. Children with autism or other developmental disorders have higher than expected rates of other medical conditions. You can see that they're 1.8 times more likely than children without developmental disabilities to have asthma, 1.6 times more likely to have eczema or skin allergies, 1.8 times more likely to have food allergies, 2.2 times more likely to have headaches, and 3.5 times more likely to have chronic diarrhea or colitis. Now we're going to talk about the assessment of autism spectrum disorder. Assessment for possible autism spectrum disorder would include, in a perfect world, evaluation by most, if not all, of these various professionals: occupational therapists, physical therapists, speech and language pathologists, psychologists, preferably one who's ABA trained, child and adolescent psychiatrist, their primary care doctor or pediatrician, possibly even a developmental pediatrician, pediatric neurologist, and possibly a geneticist. In addition, we would need input from parents, relatives, caregivers, school, and daycare staff. However, we don't live in a perfect world, and in the real world, we may need to get creative. It's important to access timely assessment by specialized professionals, but this may not be readily available. Babies Can't Wait or comparable early intervention programs typically provide speech therapy, occupational therapy, and physical therapy for children ages 6 to 36 months. A list by state can be found at the website on the slide. We need to take advantage of what is available and readily accessible. And online, these things will include telehealth services to get assessments and treatment if needed, parent education videos, and parent training videos to teach parent-mediated interventions. The Autism Speaks website has a link to the MCHAT, the Modified Checklist for Autism in Toddlers. This can be used for children from 16 to 30 months of age, and it's available in multiple different languages. We'll move on and discuss autism treatment. So, quote by an author, John Elder Robison: "Our duty in autism is not to cure, but to relieve suffering and to maximize each person's potential." So there are, unfortunately, some symptoms of autism that may require treatment. There's a long list here on the slide: irritability, tantrums, aggression, self-injury, ADHD symptoms, repetitive behavior and insistence on sameness that causes dysfunction, depression, anxiety, inappropriate sexual behavior, insomnia, communication difficulties, pica, bruxism, psychosis, as well as sensory issues that cause significant impairment. Treatment can be both non-pharmacological and pharmacological. When it comes to non-pharmacological treatment, applied behavioral analysis, or ABA, is the gold standard treatment for autism. In addition, communication supports such as speech therapy, ASL or American Sign Language, the use of picture boards and visual schedules can be very helpful. Cognitive behavioral therapy may also be important. Social skills or social cognitive training can be very helpful to these individuals, as well as can training in life skills. Occupational therapy can frequently be very helpful, not just for fine motor development, but also to help with sensory interventions for those who have sensory intolerances. And of course, physical and/or occupational therapy for motor delays or motor coordination problems. And then of course, treatment of physical medical problems. In these individuals, frequently, they'll have behavioral problems that are a result of pain, and family interventions. Other possible treatments: herbal, homeopathic, or naturopathic or alternative treatments, and diets. Right now, there's little evidence supporting these, except for the use of melatonin for sleep. Many of these possible treatments seem relatively harmless. However, they do require effort and expense that might be better used for evidence-based treatments. Ongoing research will hopefully help us to learn more about these. Other treatments that should not be used, I want to stress, should not be used, include chelation, hyperbaric oxygen treatment, secretin, or stem cell reimplantation. They should not be used because they do not work, they are expensive, and they may pose serious health risks, some of which have even caused death. So what's on the horizon? The ability to connect specific treatments to particular subgroups of people with autism is the defining hope of precision medicine initiatives. Just a little reminder that individuals with autism are always unique, totally intelligent, and sometimes mysterious. I want to thank you for your time. I hope you found this presentation helpful. And if you don't remember anything else, please remember, time is brain.